Hello. So we're back again to this time discuss sort of treatment of immune-mediated hemolytic anemia. And I think we'll sort of kick off by thinking about how do we decide when these patients need a blood transfusion?
Yeah, that's a great thing to discuss, I think, isn't it? And this is a particularly severe subset of IMHAs. So IMHA, of course, is a spectrum of disease. Not all of them will require blood transfusions, but for those that do, I would predominantly be guided by their cardiovascular parameters to dictate who requires transfusion rather than being guided by any specific number of their PCV. And so for me, if we're talking about dogs, I would be looking to see a tachycardia persistently above 120 in a dog that's euvolemic, and usually the IMHAs are, then that would be an indication for a blood transfusion for me.
Yeah. Yeah. And what sort of blood products do you use in preference, and how do you, are there any other additional tests you do prior to sort of giving dogs blood transfusions, or do you just sort of carry straight on?
Yeah, all good questions. So to answer the first part of that question, I would use packed red blood cells in preference, if they're available, in preference to fresh whole blood, for the reason that fresh whole blood contains plasma and clotting factors, and those are components of the blood that dogs with IMHA don't require. They have a specific anemia and they only need the red blood cells replacing. And so for me, it's ideal to only replace the component of the blood that they need, partly because we could increase the risk of transfusion reactions by giving them other exogenous proteins like clotting factors that they don't require, but also because you have to give more volume if you're giving whole blood. And these are patients which are euvolemic. And so if we're giving them excessive volume over and above what they need, then there is a risk that we could make them volume overloaded, and more of a problem in cats than dogs, but can be a problem in both species, is that if they are anemic, then they will get activation of their renin-angiotensin-aldosterone system. It will cause them to retain volume, and it can put strain on the heart. So if we're then giving them extra volume on top, we can push these patients into heart failure, and that's certainly something that we see happen in cats in particular.
And then if you're in a position where you don't have blood in stock and the owner wants to remain to be treated sort of in-house, and you've got, one of your colleagues' dogs is a willing donor, what's your sort of, I suppose, absolute minimum screening you would consider is needed for the donor dog?
Yeah. So, I mean, in a perfect world, I would want that dog to be 25 kilos or more. If they're smaller than that, then I wouldn't say that we couldn't use them, but I would take less volume from them. And as minimum screening, I would want to do a hematology with a PCV and total solids, biochemistry. I think that would be absolute minimum, and just confirm that they are healthy on a health check and that they're not on any current medication. If they have any other intercurrent disease, I wouldn't use them as a donor. In an ideal world, I would want to do an echo as well to confirm that they're healthy, but I appreciate that that's not always available in every situation.
Yeah. So we're looking really for a robust PCV, and I suppose the emergency of the situation will dictate what sort of number you'll tolerate, but ideally above 45 or so for me. I guess we can consider lower than that is normal in some patients, and so it's potentially acceptable to bleed them at PCVs lower than that as well, especially if you're needing that blood to save another life. It sounds like you're agreeing with that.
Yeah.
And then for the biochemistry to be completely normal, because otherwise there's an indicator that that patient's got an underlying disease. And I think although we don't need to cross-match dogs for their first transfusion, we would always, if available in-house, type them before giving blood. If you've not got blood typing available in-house, then at least reserve some of your recipient's blood so that they can be typed, and that result is not being influenced by the blood they then receive from the donor. I think also if you're going to transfuse them, it's really, really helpful to bank a few EDTA and serum samples, because occasionally, if you've sort of made a diagnosis in-house and then you get a very different result back from the laboratory, it can be really helpful just to be able to run extra tests on the blood of the patient which hasn't been transfused, which obviously could influence quite a few of our results and findings.
Yeah, absolutely. And the issue with the reason that it's so important to blood type them before they receive a transfusion is because it doesn't matter for that first transfusion, but if that patient goes on to need another transfusion after 4 or 5 days, then we need to cross-match them. And at that point, we really need to know what their blood type is. And of course, if the donor dog that we use is DA1 positive, then we can't blood type the recipient after that because they're going to test positive. So we'll never know whether they were positive or negative if we try to retrospectively blood type them.
Yeah, great. And then I think there's been quite a lot of sort of chat on discussion boards lately about the benefit of using fresher units versus older units, and some heated debate, because I think it's fairly well established in the literature. There's reasonable evidence that the older a unit is, the more pro-inflammatory it is. However, blood's a really precious resource, and ultimately, if we've got units in the fridge and we've got an older unit that's compatible with that dog, I mean, but for the first transfusion, like any unit's fine. But really, we're going to be sort of using that resource responsibly and using our oldest unit, because otherwise we're going to be throwing out blood. And I think, I just wanted to sort of flag that, because I know there's been quite a lot of chat on veterinary forums recently, and it's certainly absolutely fine to use an older unit. Great. So that's so our decision making around blood transfusions then is very much the hemodynamic status of the patient. Are they showing signs of clinically being anemic, and then giving blood rather than any overt numbers related to their PCV. And then treatment, like what's your, I suppose, the immunosuppressive treatment for IMHA. What are your general approaches? And I know mine are a bit different, so we can chat through them.
I think this is probably the area where you and I probably are likely to differ the most, more so than with our diagnosis. And I think for me, it depends on the severity of the initial presentation. I'm always going to start with immunosuppressive steroids. So either dexamethasone if they're very unwell on presentation, not able to take oral medication, which I guess for the patients that we see into ICU is often the case, or just start straight away on oral prednisolone if they are able to take oral medications. I tend to use pretty high doses if they are, if I deem them to have severe IMHA, so they're having lots of transfusion requirements, then I will tend to start with 4 milligrams per kilogram of prednisolone or an equivalent dose of dexamethasone, and I'll tend to use that for the first 5 to 7 days before swapping to 2 mg per kg, or if they go into remission sooner than that, then I would drop the dose to 2 milligrams per kilogram at that point. If I feel like they're a more mild case and maybe they don't require transfusion, then I might start with just 2 milligrams per kilogram. And I appreciate that there's some controversy over whether there's any benefit to using higher doses and whether that's really necessary, but that's what I guess I've always done.
I suppose it's useful to say before I outline my usual approach is to convert from the prednisolone dose to the dexamethasone dose, you would divide the prednisolone by about 7. Just that conversion is useful. It's not written in many textbooks, it is in some, but it's a really useful number to have in mind. So I go in at 2 mg per kg with pred. That's my first line agent. So I'll always start with prednisolone. I'll always start at 2 mg per kg. And I think for me, the other sort of important feature here is a number of these patients may have presented just pyrexic and lethargic sort of a few days prior, either for us, their primary care colleague, or to you for a different colleague in your practice. And it's not uncommon for those patients after the onset of their disease, so not with any concern for it being a trigger, but have received non-steroidals as part of their treatment. And then I guess there's a bit of decision making around, should I start steroids straight away in this patient, which will confer probably some increased risk of gastrointestinal ulceration, or should I delay that treatment? And I think my decision then depends upon the severity of the IMHA. almost always I will fall down on the decision that the IMHA is the disease that's more likely to kill them, and therefore I will go in with pred immediately, having warned the owners that there is an increased risk of gastric ulceration, but I think the risk is greater to not treating their IMHA. My perspective on that would change if the patient had really quite mild outward signs of their anemia. They were mildly anemic. They weren't really aggressively autoagglutinating. They didn't have any other negative prognostic indicators. And they were perhaps increased risk for GI ulceration because they already had GI signs on steroids or something else like an underlying enteropathy. Then I might feel happy deferring the prednisolone for 1, 2, probably not much more than that days, but I think for a lot of them, I just feel like they needed it on day 1.
Yeah, I would say I take the same approach as you. And if you have those patients where they've recently received nonsteroidals and we need to go in with steroids, do you give those patients gastroprotectants at all?
Only if there's gastric evidence of ulceration. So clear gastric evidence of ulceration. There's no benefit to me for omeprazole and sucralfate distal of the stomach. And I think most of them actually bleed in their intestines. So no, the vast majority. Are you the same?
Yes, I'm the same.
It's really nice for us actually to have these conversations because we manage these patients and sort of transfer them to one another, but actually to share each other's views is really nice. And then for me, I sort of have a fairly blanket rule, and it's flexible, but above 25 kilos, I'll start an adjunct from day 1, just because I just get really concerned about the potential for sort of hind limb muscle wastage and problems ambulating for larger dogs. I think you can probably get away with it with dogs much heavier than that, but particularly if they've got intercurrent orthopedic disease or they're particularly overconditioned. And particularly if when we start steroids, we start to see quite dramatic side effects, which we do in some. I'm really inclined to add an adjunct from day 1 for the dogs over 25 kilos, or probably the dogs Helen reaches for 4 mg per kg. They might be the ones where I start an adjunct from a time of onset preference, so long as there's no sort of GI signs or concerns. I'd usually use mycophenolate just because its onset of action is so much more rapid than a lot of the other immunosuppressives.
Yeah. And I think I have slightly different criteria for when I would add in an adjunctive. I don't worry so much about the larger breed dog side of it, but I base my decision more on the severity of the IMHA, which is quite a subjective assessment. But if I perceive that this is a very severe IMHA, so those patients that are generally very icteric on presentation, that are needing multiple blood transfusions, I perceive those patients to be at higher risk of death. And I'm much more likely to start an adjunctive agent straight away. And for those, like Jenny, I would add in mycophenolate for the reason that its onset of action is much faster than anything else that we could reach for. There's a number of studies, including a recent one that some of you may have been looking at, which doesn't really support the use of additional agents, but it's just worth noting that those studies are not well powered to look for those sorts of differences, and so it basically remains an unknown in terms of whether patients do better just with prednisolone or with multiple agents, and so that's an ongoing question that we don't truly know the answer to, but I feel like most of us feel more comfortable that with those really severe ones we would use an adjunctive agent, both for the reason of additional immunosuppression by different mechanisms of action, but also in terms of if the patient does go on to experience severe steroid side effects, if we've got a second agent that's already loaded in the system, it enables us to withdraw the steroid much more quickly than needing to add something else in downstream.
Yeah, this is it. So when I use an adjunct, I will routinely use a more aggressive steroid tapering protocol.
Okay.
So I tend to do an every 3-week tapering protocol, assuming they're in remission. And I guess we can discuss expectations around remission in a second. I'll go every 3 weeks, reduce by around about 25 to 30%. So that's steroid monotherapy. If they're on an adjunct as well, I tend to reduce their steroids by around about sort of 30 to 35% every 2 weeks, with a view to getting them off it quicker.
Interesting.
But that is very little evidence and just sort of practice and experience, I suppose. So I don't know that that's the correct thing to do, but I certainly, I don't perceive I've had any worse outcomes with that aggressive tapering if there's a second line in place. But
yeah, and I think it's probably worth just saying, isn't it, that again, there's not really good evidence about what is the optimal time to treat them for and the optimal tapering process. And I do it a bit differently from Jenny. I'm a bit more cautious in my tapering, and I tend to, unless they're having really marked steroid side effects, but I tend to taper all of mine, irrespective of whether they're on a single agent or two agents, with a tapering every 3 to 4 weeks of steroid by 20 to 25%, with the aim of getting them off steroids over about a 5 to 6 month period. And I will maintain the second agent at a static dose until they're completely off steroid, then taper and stop the second agent quite quickly after that.
And we mentioned something earlier relating to sort of owner comms, but I think it's so helpful to explicitly say to the owners at the beginning, you're likely looking at least a 6-month course of treatment. Because I think when you sort of phrase it, we'll need to do a blood test in 3 weeks and then reevaluate and then reduce the drugs, they really have very little concept of what they're letting themselves in for. And so I do like to set them up for the expectation that this isn't going to all be done in sort of 2 months' time.
Yeah.
And so that, I suppose that's how we use our immunosuppressives. And just to sort of, I guess, cover anti-thrombotics in a nutshell, or what's your approach? Because a lot's changed in this over the last 5 years.
Yeah, my favorite topic. So IMHA is a disease that we know is strongly prothrombotic, and the guidelines on the use of antithrombotic agents, there's not very many diseases where the guidelines say you should give antithrombotics for this disease, but IMHA is one of those diseases where the guideline is very clearly you should give antithrombotics, and therefore that I would consider that a standard of care now for treating IMHAs. The patients that die of thrombotic events do tend to be earlier in the course of disease, so within the first kind of couple of weeks of diagnosis, but we maintain antithrombotic treatment the whole time that they're on immunosuppressive drugs. We don't really have good evidence for that because nobody actually knows at what point they stop being hypercoagulable, if it's when they go into remission or if it's longer down the line. But what we do know is that steroids are procoagulant, and therefore, to my mind, having a dog with a procoagulant disease that's on a procoagulant drug suggests to me that I should keep them on antithrombotics for longer. I think questions around what antithrombotics do we use or should we use, and these are all questions that we don't have clearly defined answers to. Most people in general are probably most familiar with using clopidogrel nowadays, since we use it so commonly for cardiac diseases. And clopidogrel is an antiplatelet agent, so that inhibits your primary hemostasis, your platelet function. But the other arm of clotting is, of course, your clotting factors. And we do now have oral anti-10A agents available, rivaroxaban being the one that's used most commonly clinically, which inhibits your clotting pathway. And there's sort of pros and cons to using both of them. And I think one of them, there's probably two main things that we take into consideration with those. One is the length of time that each of those drugs act. So clopidogrel binds irreversibly to the platelets, and therefore once you've got clopidogrel in the system, it's going to be effectively on board for 7 days, which is your platelet turnover time. So if you have a patient that you feel like you might need to do an intervention with, where you don't really want them to bleed, or you've got a patient that is showing signs of bleeding, then that's quite difficult to deal with because you've basically got to wait a week before the clopidogrel is out of the system. Whereas on the other hand, rivaroxaban will be gone very quickly, so you can stop that and quite safely do an intervention the following day on a patient, and it's going to be gone. But the other flip side is the cost. Clopidogrel has come down in cost in recent years and is quite significantly more affordable for clients than rivaroxaban, particularly if we're talking about a 6-month treatment course for owners. So I think that's something to take into consideration with your patients. And then for me, if I've got very severe IMHAs, I will often actually start them on both agents. And that's to do with the physiology of clots. And it tends to be that arterial clots are more predominantly platelet-based. Venous clots are more predominantly clotting factor-based, although, of course, both types of clot contain both things. And the types of clots that we see in IMHA are generally venous clots rather than arterial. So therefore, rivaroxaban, in theory, should be the better agent of the two. But in reality, we don't actually, that's very theoretical, and we don't have clear evidence to back that up. And the reality for me is that these patients throw clots and die, and therefore I would prefer to do everything that I can to inhibit their chance of having a clot by giving them both agents if I feel like they have a severe IMHA where they're really icteric and they're hemolyzing very rapidly.
Yeah. Oh yeah, my preference is, so if I've got a non-cost limited client, my preference is to use both regardless of the severity of their disease. I think a lot of the morbidity and mortality in the first couple of weeks particularly is due to, thrombi formation and, as well as the sort of anemia, which can be sort of really unmanageable in some. But I suspect once these drugs have been in use in sort of duality for a period of time, we're likely to see that the prognosis of IMHA is much better than we have previously to now believed it to be. I guess we don't know that, but I hope that these drugs, which, as Helen said, are now sort of really strongly recommended and probably for clients who can afford it, standard of care, that they're likely to significantly influence the outcomes. If a client can only, or if I'm only going to use one, I'll use rivaroxaban just as for the probable predominance of venous clots, but that'd be my one. If I've got a really cost-limited client, I'm happy to give them aspirin as a sole antiplatelet agent. Like, that's far and away the cheapest option, and it's better than nothing. And we've got evidence for that drug being better than not using it. Yeah, I think that's probably.
Yeah, and I would do the same. That in preference, I'll often give both. In preference, if I can only give one, I'll give rivaroxaban. But if the clients really can't afford it, then I would go clopidogrel next. And then if they still can't afford that, then aspirin is a backup option. Yeah. And I think it's just worth emphasising that I would give some form of anticoagulation to all IMHAs, irrespective of severity of their disease.
100%. Yeah, 100%. And then how do you, I suppose we're sort of looking to wrap up now, but how do you define remission? I guess at two time points. When are you hoping to demonstrate remission? And then how are you defining remission on your repeat hematologies to enable you to feel comfortable to taper their drugs?
Yeah, so I guess for me, I would hope to identify remission at the first time point where I would be looking to taper the steroids. So realistically, after about 3 weeks or 3 to 4 weeks. And for me, remission would be a combination of a PCV of 35% or above, with an absence of a reticulocytosis, so an absolute reticulocyte count less than 60. And for me, if the reticulocyte count is above 60, even if the PCV is above 35, I wouldn't taper the steroids at that point, because to me that suggests that the patient is just in equilibrium. They're still hemolyzing, but they happen to be producing their replacement red cells at such a rate of knots that it's just maintaining a static PCV. Yeah. And I think those are the ones where if you don't check the reticulocyte count, you only go off the PCV and you taper the steroids, they're the ones that where they can then suddenly have an apparent relapse. And it's probably not technically a relapse, it's just that they weren't really in remission to start with.
Yeah. And I think the only thing I'd add to that is, although we don't necessarily expect them to be in full remission until that time point, we really want to see sort of robust evidence of a response to the therapy within a week to feel that our therapy is being effective. If our patients are still really sort of transfusion dependent 5 to 7 days in, for me, that's a time where if I've only started them as sole agent, I'm thinking about whether I want to add a second drug or not.
Yeah, absolutely. Yeah, I agree.
I think for us, that's everything that we wanted to share with you. As always, we're really happy to have suggestions for future sessions you want us to run, and we look forward to seeing you at a session in the future.
Thanks very much. Bye.
Bye.